For surgical release of carpal tunnel, the first important thing is the correct marking. The Kaplan line is identified first, which is drawn from the interdigital fold of the thumb and index finger toward the ulnar side up to hook of the hamate. Another line is drawn from the radial side of the ring finger up to the point where it intersects the Kaplan line. The meeting point is the landmark of distal limit of our incision mark, because if we go beyond this line, there is chance of injury to superficial palmar arch. The proximal limit of incision mark is distal wrist crease. The incision line is drawn little ulnar to the thinner crease to avoid injury to the superficial cutaneous branch of median nerve. Now the incision is made along the previously marked line. The incision is deepened up to the subcutaneous tissue. The next structure we can identify here is the palmar aponeurosis. So you can differentiate this palmar aponeurosis from the retinacular ligament by seeing the orientation of the fiber. The fibers are oriented here longitudinally, where in retinacular ligament the fibers are oriented transversely. By putting incision over the palmar aponeurosis and careful dissection, you can identify the origin of the thinner as well as hypothenor muscles. So this is the flexor retinaculum and its fibers are oriented transversely. A careful incision is made over the retinaculum, and you will see the median nerve just under it. Now extend the incision over flexor retinaculum distally and proximally, and it can be done by knife with protecting the structures below the ligament with a forceps underneath the retinaculum, or you can use scissors as well. The fat pad distally indicates the last limit of dissection. The color of this fat pad is different from the subcutaneous fat. Now extend the incision proximally to release the retinaculum fully on the proximal side as well to prevent the recurrence. So this is on the proximal side, the nerve is enlarged, but here is the compression side, the nerve is flat. And similarly, distally, you can see the nerve is enlarged. So this part was basically compressed. Wound closure was done by interrupted vertical mattress suturing using 4O prolene.